So, today's topic of discussion is the drugs used in treatment of malaria, and malaria is, how important malaria is. You can see everywhere. It is everywhere in our country. We are endemic zone for the plasmodiums, the parasite behind causing this disease, malaria, and mostly nowadays the drug of choice. Earlier, the drug of choice, which was earlier the drug of choice, that is chloroquine, and most of the plasmodium in our country are now resistant to it. So there are many more drugs to be, prescribed for the treatment of malaria. So we will see that one by one. Right now, you can see here the specific learning objectives. What we want after this session is that you should be able to classify the antimalarial drugs, the classification of drug, which is one of the most important part of pharmacology. Then mechanism of action of all the antimalarial agent, which is very important to know. And then what are the risk and benefit associated with those drugs? It means the benefits means in terms of efficacy and the risk in terms of ADRs. And then as per national guidelines, what is the prescribed uh, prophylaxis and treatment for malaria. This we will discuss, and then uh, at the end, you will be able to write and articulate and explain and treat a patient of complicated or uncomplicated either virus or falciparum or malaria. So this is all. This is the agenda. This is the objective which we will cover in this topic. So here we go. This is the microbiology part, which you all know that causative agent for malaria is Plasmodium, of course, and there are four species which causes malaria. All the Plasmodium causes tertian malaria, that is the fever comes every third day. But there is one species of Plasmodium, that is Plasmodium malaria, which causes cotton malaria, that is the malaria comes on fourth day. Plasmodium ovale is not detected in our country. So we have these three: Vivex, Falciparum, and malaria so far. So this is the life cycle. Again, the microbiology part, which you read in deep in that subject. Here we are focusing just to know. Basically, we are targeting few stages of life cycle of parasites. So that's why we need to know. So there is one pre-erythrocytic phase, there is one erythrocytic phase, then there is one post or extra erythrocytic phase. So these are things which you need to know. That's why I am showing you this. So here you can see the entry of the parasite into the human cells, and it goes to tissue as tissue side, and then in as hypnocyte in liver, and maybe it goes to the blood. In blood, it either goes to the red blood cell or it remains in the tissue for some time. So if it goes in the blood, it will destroy the blood cells, and again it will release. Some of them remains there in the body, and some of them becomes the male and female gamete, which combine to form the parasite again, and it goes. So the targets we have right now in pharmacology are as pre-erythrocytic targets, erythrocytic target, post or extra erythrocytic target, and gametes. So we will go that way in classification of our drug. So this life cycle of Plasmodium, I hope you all already know and read from microbiology book, which is very important to know. So this is malaria transmission cycle again. If we start from mosquito to human, sporozoites injected into human host during the blood meal. Basically, this also that Anopheles mosquito, that too the female Anopheles mosquito is responsible for, is a vector for malaria. Why female only, not male? Because mosquito are mainly frugivorous. They survive on fruits and plants fluids, not the humans or mammal secretion. But for Anopheles, female on Anopheles mosquito to protect its egg, they need some warmth. So that's why they fed on mammals' blood, not only humans but animals also. So that blood, we are warm-blooded animals, so we give them warmth, and hence only female mosquito bites. And during this bite, it transfers the spore if it is infected. Not all the female Anopheles mosquito are infected. That is also one thing. Fortunately, not all are infected. So every mosquito bite will not lead to dengue or malaria. This is something which you should know. So sporozoid transfer to the blood of human, and then in human there is one exoerythrocytic hepatic cycle where sporozoids infected liver cell and develop into cyzones, which release murozoite into the blood. And then there is one dormant liver stage where hypnocyte remain in the blood for some time. It will not release into the blood. It remain in the liver and the tissue. Then erythrocytic cycle where murozoites infect the red blood cell and they form cyzones, and then they destroy the red blood cell, and there is a release of lot of cyzones, and which leads to the symptom of fever and chills and rigor. So every third day and every fourth day means that this much of time that particular species need to release a cyzone, bout of cyzones. Then some merozoids differentiate into male and female gametocyte. They combine to form the egg and then undergo further sexual reproduction in the mosquito. Okay, so this all sexual, asexual reproduction, this all transmission cycle, life cycle, you need to read thoroughly from the microbiology part. We are here discussing just to, just because we are going to classify our agents on the basis of this erythrocytic gametocidal drugs. So that's why we are reading it. So this is something which you need to remember. From here, there are two terms which are very, very important as far as malaria is concerned. You need to know relapse and recurrence. They are not the same. There are difference. Recurrence is when symptoms return after a symptom-free period, right? It is due to the parasite surviving in the blood as a result of inadequate or ineffective treatment. See the difference between relapse and recurrence. Relapse and recurrence difference is very, very important to understand because one species of Plasmodium, that is Vivax, is known to cause relapse. Another one is Falciparum, which is known to cause recurrence. There is no relapse in Falciparum. So, because we need to give treatment on the basis we protect the inadequate killing or ineffective killing of the parasite. They are there only. While relapse is something which is the body, human body is when symptoms reappear after the parasite have been eliminated from the blood, means the body is free from parasite, is still the symptoms reappear, right? But persist as dominant hypnocyte in liver cells. So you can see here there is no uh, liver cell dormant state in falciparum. In falciparum, there is because of inadequate treatment, symptom reappears. That is not relapse, that is recurrence. Okay, so parasite is there, symptom-free period comes because of the initial treatment, because you kill the erythrocytic cyzones. So a patient becomes symptom-free, but because of inadequate killing of the parasite, which are there in exoerythrocytic part or in some basically exoerythrocytic part, they again produces cyzones and the symptoms again occurs again. So the difference between relapse and recurrence is in recurrence, parasite is there in the blood. In relapse, parasite is eliminated from the blood, but there are some persistent liver cells, hepatic phase of life cycle where from where it can come again into the blood and leads to relapse of the disease. So relapse and recurrence are two different things. Relapse is always with Vivax, not with falciparum, and recurrence is always with falciparum. So there is a classification on the basis of their chemical structure, which is not very important to read. Remember the chemical name. You can just remember the groups in which you need to remember the drugs. Like if you talk about chloroquine, you should know the chloroquine as well as Piperaquine and Atovaquone. They all are in one group. Then in quinoline, methanol, Mefloquine is one drug, right? So you need to remember the name, and we will classify on the basis of their mechanism of action later on. Then cinchona alkaloid, you will find quinine and quinidine, which nowadays obsolete. We don't use this because of the lot of toxicity, but earlier it was a drug of choice. Then biganites like Proguanil. Biganites are another group of drugs which you will read in treatment of diabetes, where biganites are the hero of treatment of diabetes. Metformin comes to that group, so you will see that there also. Then comes some diaminopyrimidine, where pyrimethamine is one of the drugs. Then primaquine, a very very important drug as far as treatment of malaria is concerned. It is something which is given always. We will see that. Then sulfonamide group of drugs and antibiotics, some clindamycin, doxycycline. So there are some antibiotics which are antibiotics means antibacterial drugs which can be used for treatment of malaria. We will see in some regimen you will find. For example, doxycycline is used in treatment of short-term prophylaxis of malaria. We will see that. Then there is a latest entry into the treatment of malaria, like artemisinin group, where you will find all these drugs: artesunate, artemether, arteether, arterolin. These are actually nowadays the first line drugs. And there are some drugs like amino alcohols like halofentrin, glumefentrin. These are also in combination with artemisinin. We use these drugs. Then atovaquone and pyronaridine. These are also used in some regimens. So name you should know that. Then now there is a classification proper. So that classification you just saw is on the basis of their chemical group, but now on the basis of what what stage of life cycle of parasite they are targeting. So if you see tissue zoononticides, so what are the drugs amongst which we just saw which can penetrate the tissue and kill the parasite? So primaquine is the drug there, and hence it is very very important. So here it is, the dose is mentioned that 50 milligram per day for 14 days we need to give to, these tissue isonticide are actually responsible for relapse because they are there in dormant phase. After you clean by targeting the erythrocytic phase of plasmodium by some very highly efficacious antimalarial drug, symptoms will go, parasite will go from the blood, but the dormant parasite from the tissue will come again and leads to the relapse. And hence, it is very important to give Primaquine 15 milligram per day for 14 days to prevent relapse in Plasmodium vivax, along with other drugs. So, apart from Primaquine, Proguanil, which is the biganide, and doxycycline, which is one of the antibacterial drugs, are also killing the tissue sisons. Then gametocides. Again, primaquine is having gametocidal action. So primaquine is actually having all the actions. This is good about primaquine, and hence you will find primaquine in all the regimens. And it is gametocidal for all the species. There is no discrimination between vivax and falciparum. 45 milligram single dose is given to kill the gametes. So you can see here, 15 milligram per day for 14 days is for tissue sisonticidal action, and primaquine 45 milligram, a high dose single dose is for gametocidal action. So here there is dose dependent action of primaquine as tissue isonticide and gametocide. So you can see in regimen of Plasmodium vivax treatment, you will find primaquine as 15 milligram per day for 14 days because there we want to prevent relapse. While in falciparum malaria, you will find primaquine again, but not for prevention from relapse. This is very very important. In falciparum also we are giving primaquine. In vivax also we are giving primaquine, but the purpose is different. In vivax, the purpose is to prevent relapse, and hence the dose of primaquine is 15 mg per day for 14 days. While in falciparum, the purpose is to kill the gametes. Okay, so because when you kill the gamete, another mosquito, if it fed on the human blood, it will not get infected. There will be no further sexual reproduction in the malaria. So there will be no spread of malaria in the community. So for that purpose, we give primaquine 45 mg single dose. So it is very very important to understand that primaquine is given in both vivax as well as falciparum, but for different purpose and at different dose. So primaquine should be given immediately after clinical cure, and it will cut down the transmission to the mosquito and then to the community, which I already told you. And now there are few terms which you can see like clinical cure. Clinical cure means terminate the episode of malaria fever. A patient comes to you with the symptoms. At that point of time, the plasmodium sisons are in the blood. You will give the drug that will target the erythrocyte. Very efficacious, highly efficacious. And in 3-4 days, the termination of episode of malaria fever will happen. That is what we say the clinical cure. That is the clinical relief given to the patient by our drug. Then what is radical cure? Radical cure is the treatment given along with clinical cure. That is now clinically you cure the patient, but now you want to prevent the relapse. So you target tissue cyzones as well. So you add primaquine and other tissue cyzones to kill the hepatic and erythrocytic stages. Then what is causal prophylaxis and what is suppressive prophylaxis? Being the term prophylaxis, you know that there is no infection, there is no disease. It is a prevention. But what is causal and what is suppressive? Causal is when you are targeting the pre-erythrocytic stage. That from pre-erythrocyte, the parasite will go to the erythrocyte and will lead to the disease. So before that only, before erythrocytic stage, if you are targeting, then it is known as causal prophylaxis because the cause of the disease you prevented. And suppressive is when in erythrocyte only you are giving that before cyzones release into the blood so that the disease gets suppressed. So before, so this is the two difference between the prophylaxis causal and because you are targeting the cause, and suppressive because you are suppressing the main target. So in clinical cure, we give erythrocytic isonticide, which is used to terminate the episode of malaria fever. They are classified into high efficacy and low efficacy. So classification is going on right now. So far, you know now the gameticides like Primaquine. Then you already know the tissue isonticides, that is Primaquine, Proguanil, and Doxycycline. Now we are talking about erythrocytic isonticides. So high efficacious and fast acting means this group of drugs. Artemisinin fastest now drug of choice, chloroquine, amodiaquine, quinine, which is now not used, mefloquine, halofentrin, lumefantrine, atovaquone. So these are the drugs which are highly efficacious and our first choice. Then low efficacious, low acting, you will find proguanil, pyrimethamine, sulfonamide, tetracycline, and clindamycin. So there is no primaquine. The only place where primaquine is not very effective is the erythrocytic side phase. Otherwise, everywhere in pre-erythrocytic phase, extra-erythrocytic phase, or tissue sizome or gametes, everywhere you will find primaquine. So this is how you will classify antimalarial agents. If we say classify antimalarial agent on the basis of their chemical structure, which is very rarely asked because we don't expect you to remember the clinical structure. So that is the classification. And the mostly we ask the classify antimalarial on the basis of their mechanism of action, where you will find out not exactly the mechanism of action, but the target. So here you will say erythrocytic isonticide, tissue isonticide, gametocidal drugs. Then in erythrocytic, you will say high efficacious and low efficacious. So what is radical cure? We just saw that clinical cure is the when the patient comes with the symptom, you are treating the symptoms at that point of time. You are giving high efficacy, high fast erythrocytic isonticide like artemisinin group of drug like chloroquine, quinine, atovaquone, mefloquine. While for radical cure, we are targeting both erythrocytic as well as hepatic stage so that it will not come again. The parasite which is in dormant stage, we need to target that. So it is seen in Vivex and Ovel. Ovel is not in our country, so Vivex only. And here we give erythrocytic isonticide as well as tissue isonticide. So erythrocytic isonticide like chloroquine, if the parasite is sensitive to chloroquine, if resistant, then we will go for artemisinin group of drugs. And primaquine we are adding to kill the tissue dormant phase. The dose is 15 mg per day for 14 days. Here because we are giving chloroquine to prevent the relapse. In case of chloroquine resistance, either quinine, which is not used nowadays. So the second one, that is artemisinin-based combination therapy, we called it ACT, which we will discuss along with primaquine. So primaquine is very, very important. Then if you talk about causal prophylaxis, where we are targeting the pre-erythrocytic phase, which is the cause of malaria infection, this I already discussed. That if you are targeting pre-erythrocytic phase, we call it causal prophylaxis because you are targeting the cause of the disease. So the clinical attack is target for this purpose, and primaquine is the causal prophylactic for all species of malaria. Again came primaquine. You will see primaquine is not there in erythrocytic phase. It is not effective, but rest everywhere primaquine is very, very effective. Suppressive prophylaxis is something where isoniazid which suppress the erythrocytic phase. So you are giving the drug which are suppressing the erythrocytic phase, not pre-erythrocytic. So now it is suppressive. So thus attack of malaria fever can be used as prophylactic, and clinical disease does not appear. This is mostly we give to the patient who are traveling to the endemic zone. So the patient, when the not patient, we will not use the term patient when we use the term prophylaxis, because patient is when the disease is there. Prophylaxis is when we are giving the drug before the disease happen, because you want to prevent that person to get the disease. So in those cases, if you are traveling to a zone which is non-endemic, or where there is no malaria, to the zone which is endemic for malaria, so you can take or you can prescribe your patient some drugs to suppress the erythrocytic phase. So chloroquine not is used in India because of the resistance. Otherwise, there is regimen for that. So two drugs which are responsible, which are very, very important for you to which is which you should remember. These two drugs, Mefloquine and Doxycycline, are two drugs. Please remember these two names whenever somebody asks you about suppressive prophylaxis. That two divide into two: long-term prophylaxis and short-term prophylaxis. If the stay is of more than 6 weeks, means if a person is traveling from non-malaria zone to malaria zone and he is going to stay there for more than 6 weeks, you will choose Mefloquine, because Mefloquine is a drug which can be given weekly. So it will be more, the patient will be more compliant. For 6 weeks, a weekly drug would be more preferred as compared to the daily dose. So Mefloquine can be given 250 mg weekly. Here the dose is regimen is like it should be start 2 weeks before the travel. So the date of travel se 2 week pehle you give Mefloquine 200 mg weekly. Then during the travel, obviously travel will be less than a week, so it will be taken for 4 weeks after return from the end of the exam. So 2 weeks before the travel date, then during the stay, and then after coming back home, we should continue it till 4 weeks after return as well. So 2 weeks plus the whole period of stay plus 4 weeks after return from the endemic area, 250 mg weekly is the dose for long-term prophylaxis. This is very, very important to understand. And short-term prophylaxis is when the stay is less than 6 weeks. The first thing is you should know what is the definition of suppressive prophylaxis. What is the different definition of causal prophylaxis? What is the difference between causal and suppressive prophylaxis? Then you should know what is short-term prophylaxis and what is long-term. And obviously, we are talking about suppressive prophylaxis. So less than 6 weeks short term, more than 6 weeks long term. Chloroquine is the drug of choice if there is sensitivity to the chloroquine. In India, the chloroquine resistant developed. So now for long term prophylaxis, we give Mefloquine. For short term prophylaxis, we give Doxycycline, because Doxycycline is a daily drug. So we can not give it for a period of when the period of stay is more than 6 weeks, because of the issue of compliance. So if there is less than 6 weeks of stay, you can give 100 mg daily. Start 2 days before the travel, during whole stay, and till 4 weeks after return from endemic area. It is same for both Mefloquine and Doxycycline. So this is very, very important to understand. 2 weeks prior to travel date, whole the period of stay plus 4 weeks after return for Mefloquine, 200 mg weekly, long term prophylaxis. Short term prophylaxis, 100 mg daily, doxycycline, 2 days, 2 days, not 2 weeks, 2 days before travel, during the period of stay, and again continue till 4 weeks after return from the endemic area. Because doxy is contraindicated in pregnant women and children less than 8 years of age, we cannot give it to them. So this is the regimen where chloroquine sensitivity is there. If chloroquine sensitivity is there, the regimen for prophylaxis is chloroquine 300 mg per week in combination with Proguanil 200 mg per day. As an alternative to Mefloquine, we can give in long-term prophylaxis, and Atovaquone 200 mg plus Proguanil 200 mg one daily 2 days prior to 7 days after the exposure. So these are two additional regimen apart from Mefloquine and Doxycycline. So all the regimen for prophylaxis you need to remember. Chloroquine sensitive as well as chloroquine resistant. Now, what shall we do with the pregnant lady? As we said that the drugs which are contraindicated, which we are using for prophylaxis in normal population, but in pregnancy they are contraindicated. So there is one regimen for suppressive prophylaxis in pregnancy. Again, it is a very special regimen. You need to remember it. Here, a combination of pyrimethamine and sulfadoxine is given. So one dose each in second and third trimester. 1 month gap should be there between two doses, and it should be given to the pregnant lady who are living or residing in the areas with high Plasmodium falciparum endemicity. Okay, so Plasmodium falciparum is a cerebral malaria which is very very dangerous uh, infection. It can be life threatening. So in pregnant lady, it is prophylactically pyrimethamine sulfadoxine combination is given, two doses, one in second trimester, one dose each in second and third trimester, and there should be minimum 1 month gap between the two doses as recommended by the guideline. Now, what is the goal? Actually, what so far we have gone through all the uh, you know targets and the name of the drugs. But what is the goal of treatment? So the goal is to prevent and treat clinical attack of malaria. First thing is prevention, which is not very very effective, as because you cannot prevent the every population moving from here and there. So prevention, there are many methods of prevention of malaria which you can read. You can read from your PSM book. So there are many measures at the level of mosquito, at the level of parasite, at the level of human. So with this, all you know, you should read. Otherwise, to treat the clinical attack of malaria, we will see that how to treat. To completely eradicate the parasite from patient's body, this we already see that we should give Primaquine 15 mg per day for 14 days to prevent relapse, complete elimination. And to reduce human reservoir of infection, cut down transmission to the mosquito. So, if you want to cut down transmission to the mosquito, you can give gametocide. Again, Primaquine 45 mg single dose is given. So from here, let's start our drug one by one so that you should know about the drug, the pharmacology of drugs per se. Chloroquine, which is the drug of choice in case of chloroquine sensitive malaria, obviously. It is a rapidly acting erythrocytic zygoside, as you saw already. Chloroquine has been classified in high efficacy, fast acting erythrocytic zygoside, and it controls most clinical attacks in 1 to 2 days with disappearance of parasite from peripheral blood in 1 to 3 days. So within 1 to 3 days, the clinical cure happens. But obviously, we need to uh, prevent the relapse as well. So we need to give Primaquine along with chloroquine. No effect on pre-erythrocytic and exoerythrocytic phases. That's why relapse can happen. So that's why we need to add Primaquine. So it cannot prevent relapse. It is only for clinical cure. Mechanism of action of chloroquine is very very important. It is actively concentrated by, this is important, okay, chloroquine, quinine, artemisinin group of drugs, Primaquine, their mechanism of action is very very important to understand and remember. So chloroquine is actively concentrated by sensitive intra-erythrocytic plasmodium. That is very, this is good thing. That's why chloroquine is effective in erythrocytic phase, because it gets concentrated in those in intra-erythrocytic plasmodium by accumulating it in the acidic vesicle of parasite. So, being weakly basic in nature, it raises the vesicular pH. So, the chloroquine is basic in nature, it will increase the pH of acidic vesicle of the parasite, which leads to interference with the degradation of hemoglobin by parasitic lysosome. Right? So, because parasite is feeding on the hemoglobin, so parasitic lysosome are degrading hemoglobin for its survival. where chloroquine reaches to that acidic vesicle and increases the pH and interfere with this degradation of hemoglobin by parasitic lysosome. Then polymerization of toxic heme to non-toxic parasite pigment hemozoin is inhibited by formation of chloroquine heme complex. So what was happening is, so when parasite breaks hemoglobin, there is some toxic heme released. That parasite is actually converted to non-toxic pigment hemozoin. This conversion of toxic heme to non-toxic parasite pigment hemozoin is inhibited by chloroquine heme complex because chloroquine raises the pH, which is interfering with the degradation of hemoglobin. So now this toxic heme is actually responsible for killing the parasite. So heme itself or its complex with chloroquine that damage the plasmodial membrane, and which leads to clumping of pigment and changes in parasite membrane follows the death of the parasite. I hope all of you got the mechanism of action of chloroquine. So what is happening? Let's see again. Chloroquine is actively concentrated by sensitive intraerythrocytic plasmodium, okay, by accumulating it in acidic vesicle of the parasite. So all the erythrocytes which are infected by parasite, they are taken up the chloroquine. Concentration of chloroquine increases in that cells. Now, because chloroquine is weakly basic in nature, it will increase the vesicular pH. So there is some disturbance between the pH in the pH inside the parasite vesicle, which leads to interference with the degradation of hemoglobin by parasitic lysosome. So now this degradation of hemoglobin will not happen. So now what happens is the polymerization of toxic heme to non-toxic parasite pigment hemozyne is inhibited by formation of this chloroquine heme complex. So this chloroquine heme complex now preventing the conversion of toxic or non-toxic pigment hemozoin. So heme itself or its complex with chloroquine that damage the plasmodial membrane because it is toxic to the parasite, which leads to clumping of pigment and change in parasitic membrane, leads to death. Similar mechanism of action you will see with amodiaquine, quinine, mefloquine, lumefantrine. So there is no need to discuss the mechanism of action of quinine, mefloquine, lumefantrine, amodiaquine differently. So this is the same mechanism of action with these drugs as well. What is the mechanism of development of resistance to chloroquine? Because now the whole of the country is now the plasmodium here in our country is resistant to chloroquine. But still we are giving chloroquine to some patient, they respond. But nowadays the drug of choice is artemisinin because chloroquine, we cannot, count on chloroquine to treat our patient. So resistance is reduced uptake and transport of chloroquine to food vacuolar plasmodium. This is one thing which can a parasite, a plasmodium can do to prevent itself from dying by chloroquine, killing by chloroquine. So it will reduce the uptake and transport of chloroquine. First thing. Second thing, there are some efflux forms. Okay, there are some efflux forms which can be coded by PFCRT and PFMDR gene. These are some multi-drug resistant genes. Plasmodium falciparum multi-drug resistant gene. So efflux pump, the action of efflux pump is where the whatever chloroquine comes inside the cell will be efflux out. So there will be no effective concentration of chloroquine will be there in the vacuole, which will change the internal milieu, that is the pH of the vesicle, and the further mechanism action will stop. So, pharmacokinetic of chloroquine, because mostly we give chloroquine orally, it is widely distributed. And the good thing about chloroquine is that it gets concentrated into many tissue because of very, very high volume of distribution, liver, spleen, kidney, lungs, skin, leukocyte, and other tissue. And that's why it is useful in many other conditions as well as apart from malaria. But again, this is two-edged sword. The volume distribution because of higher accumulation in retina, which is the prime target for chloroquine to get accumulated. There are high chances of ocular toxicity because of the chloroquine. It is metabolized in liver and excreted in urine, and T half is 3 to 10 days because of the tight tissue binding. So plasma protein binding and tissue binding is very, very high. So chloroquine remains there in body for longer time. That's why one just to increase the concentration of chloroquine, we give the loading dose of chloroquine. Otherwise, one daily dose is sufficient. Adverse effects are the common one are GI side effects, which you all know that all the antimalarial drugs are actually causing GI intolerance, like nausea, vomiting, abdominal pain, headache, anorexia, malaise, urticaria. So it is always advised that the patient should take antimalarial agents after their meal. Okay, just to reduce this GI toxicity. Long-term administration of high dose of chloroquine for rheumatological disease can result in loss of vision. So you will see, apart from malaria, there are other uses of chloroquine. Okay, we'll see that. So when you are using the chloroquine, here in malaria, we are using chloroquine for 3 days. But in inflammatory diseases, autoimmune diseases, where we use chloroquine for long, very, very long duration, the accumulation of chloroquine into the retina will lead to the retinal damage. And there is a very, very specific bull's eye maculopathy has been noticed with the chloroquine. So bull's eye maculopathy is a peculiar uh, retinal damage caused by chloroquine over a long period of treatment. Apart from that, there are some reversible side effects like corneal deposits may be seen. And very rarely, but yes, chloroquine can precipitate attack of seizure, psoriasis, and porphyria, which is important to know. Contraindication and cautions are in liver damage because it is metabolized in liver, so it will lead to toxicity. Or in case of severe GI diseases or neurological or retinal hematological diseases, we should not use chloroquine. So very, very safe drug actually, and safe in pregnancy and young children, as well as very, very safe drug as far as ADR is concerned. Apart from GI intolerance, very other side effects are very rare. So not at all a big deal. So this slide is very, very important. So if I ask you what are the uses or indication of chloroquine apart from malaria, so for you must know that it has action on entamoeba histolytica, cardiac. So these are amoeba basically. So in amoeba, also chloroquine is used. In anti-inflammatory disease, also it is being used. It will cause local irritation, and local anesthetic action is also there. It is having weak smooth muscle relaxant property, antihistaminic and antiarrhythmic property as well. So antiarrhythmic property, quinine, maybe you will see, you already, maybe CVS is complete. So you already read quinine as an antiarrhythmic property. So chloroquine also shares some antiarrhythmic property. So the use of chloroquine, obviously, because the main use is malaria. In malaria, also clinical cure for Vivax, Ovel, and malaria. And if falciparum is sensitive, then in that also. So for clinical cure of basically Vivax and falciparum strain. And it is very, very efficacious and very, very fast acting drug because it causes rapid clearance of fever and parasitemia. So बहुत जल्दी से symptom free हो जाते हैं patients. But apart from malaria, just remember there are other diseases where we can indicate chloroquine use, like giardiasis, like extraintestinal amoebiasis. Another name for the same is hepatic amoebiasis or amoebic liver abscess. Okay, this is just because there is chloroquine is having very high volume of distribution, so it get accumulated in the tissue. We will see that when we read anti-amoebic drug, we will see that. Then in rheumatoid arthritis, as I said, anti-inflammatory property is there. So in rheumatoid arthritis, you will find chloroquine. In discoid lupus erythematosus, in Lepra reaction, photogenic reactions, infectious mononucleosis. So please remember these extra indications of chloroquine, which is very commonly asked question in your theory as well as in your viva. So giardiasis, amoebiasis, rheumatoid arthritis, discoid DLE, Lapa reaction, photogenic reactions, infectious mononucleosis are other indications for the use of chloroquine. So dose is important to remember. Many times the student asks, shall we need to remember the dose of all the drugs we read in pharmacology? I always tell them that no need to remember the dose of each and every drug, but all the drugs which comes under some regimen like national guideline for malaria, national guideline for leprosy, national guideline for TB. In such condition, ARTs, antiretroviral therapy. In these conditions, you need to remember the dose, the complete regimen, not only the dose but the frequency and the duration as well. So the dose of oral chloroquine phosphate is the base is means the salt of 250 mg contains 150 mg base. It means 250 mg tablets जो आपको market में मिलेगी, it contains 150 mg base of chloroquine, and we always calculate the dose on the basis of base. What base is there, not on the basis of the salt. So for Vivex and Ovel, 600 mg base. So 600 mg base means 500 mg tablet you need to find. The 500 mg tablet contains 300 mg. No, 500 mg contains, 300 mg. You need to give 4 tablets of 250 mg or 1 gram or 1000 mg. Contains 600 milligram base, followed by, so this is the loading dose, followed by 6 and 8 hours by 300 mg, and then 300 mg daily for 2 days. This is the regimen for treatment of Plasmodium vivax malaria, which are chloroquine sensitive. Apart from oral, intramuscular and intravenous can preparations are there, but there is no indication for intravenous. And intramuscular causes local tissue toxicity, so we avoid it giving by intramuscular route as well as. So large intramuscular injections or rapid intravenous infusion of chloroquine can result in severe hypotension, arrhythmia, and seizure, and hence not recommended. So this is a very good and important question from the pharmacokinetic of the chloroquine. If somebody asks you that why should we avoid the parenteral administration of chloroquine, you must say that the by parenteral administration of chloroquine, the chances of severe hypotension, arrhythmia, and seizure is there, and hence it is not recommended. So this is about this was about chloroquine. Here we come again to another drug, that is Atovaquone, which is identical to the chloroquine. So everything is identical. We are not going to discuss it. Mechanism of action is same. The accumulation into the parasitic vacuole raise the pH, which interferes the degradation of toxin heme into non-toxic hemazoin. So that toxic heme, along with chloroquine, will lead to the destruction of the parasitic. There is clumping of pigments, and this leads to the death of parasite. The same mechanism action here also, same mechanism of development of resistance as well. All the uses and adverse effect are also very similar. Advantage it is less bitter and faster acting than chloroquine. This is the advantage or difference from chloroquine, and it is widely used nowadays, which leads to reduction in cost of treatment. Safety is increased, and the activity against chloroquine resistant falciparum is also increased. There are some different ADR with this drug, like agranulocytosis and hepatotoxicity. So we cannot use it for long-term prophylaxis or long-term treatment. Not seen with short-term use, so clinical cure के लिए we can use drug Atovaquone. So it is used in clinical cure of falciparum malaria without chloroquine resistance. So these are some options available for us if there is a resistance to the chloroquine. It is not used for prophylaxis because chloroquine also not used for prophylaxis. Clinical cure के लिए बस हम use करते हैं. We will see the combination formulation of Atovaquone with the artesunate. So it this combination formulation with artesunate has been recently approved for the use of in uncomplicated falciparum malaria, irrespective of chloroquine resistance status. And in African country, the regimen is available. This is the regimen where artesunate 50 mg and amodiaquone 150 mg, 10 tablets are there. Let's come to Primaquine, which is very, very important. Again, I told you that apart from erythrocytic, you will find Primaquine in every stages like gametocytic action, hypnozoids, pre-erythrocytic cyzones, everywhere. So it is a poor erythrocytic cyzonticides, so we do not use it for clinical cure, but we use it again with the agents which are used for clinical cure like chloroquine to prevent the relapse. It is highly active against gametocyte. I already told you 45 mg single dose we give to kill the gametes, and also for hypnozoids to prevent relapse as well as prevent the transmission of malaria to the mosquito and to the community. Mechanism of action you will see here is this primaquine converted to quinone, which inhibits the coenzyme Q of the parasite, and it interferes with the respiratory process, that is electron transport chain, and leads to the parasitic death. So this much of mechanism of action is important to remember. I already discussed this radical cure and gametocidal action. So this is the primary indication, means either in Vivex for prevention of relapse, 15 mg per day for 14 days, or in falciparum for gametocidal action like 45 mg single dose. So if there is chloroquine sensitive falciparum malaria, we always give chloroquine primaquine combination, where primaquine is given in single dose of 45 mg to prevent the transmission of malaria to the mosquito. Adverse effect of primaquine, GIT toxicity, as I told you, with all the antimalarial agents. Apart from that, dose-related hemolysis, methemoglobinemia, tachypnea, cyanosis are very, very important due to the oxidant property of primaquine. So the patient with G6PD deficiency should not receive it. It will lead to the hemolytic anemia, even in very, very small dose. So it is recommended and advised that before starting antimalarial treatment, it is always wise to know the G6PD status of the patient, but because in periphery, in many part of our country, there is no such facility to detect the G6PD deficiency. So what we do is we give, this drug very cautiously and always counsel patient to come in as soon as if there is any kind of bleeding symptom or sign the patient see, they should report. Tafenoquine is a new drug which is long-acting erythrocytic cytotoxicity, and it is developed as single-dose anti-relapse drug for Vivex malaria. So, in replacement of Primaquine, which is given 15 mg per day for 14 days to prevent relapse, there is some drug. There is a drug Tafenoquine is launched, which can be used. It is not used in our country, but you should remember the name Tafenoquine. Mefloquine, again, chemically related to the quinine, we'll see. So they are also the same mechanism of action as that of chloroquine. Rest everything we already discussed that they comes under the classification of fast-acting, high-efficacious erythrocytic cytotoxicity. There is no action on hepatic or gametocytes, so they are only for clinical cure. And they are active against chloroquine sensitive as well as resistant. So if there is chloroquine resistance, we have these options at Atovaquone and chloroquine. So for single dose 15 mg per kg controls fever and eliminates circulating parasite. Used for both the species of Plasmodium vivax as well as Falciparum. Almost all the drugs are used for all the species until unless there is resistance. But Falciparum are mostly resistant to the chloroquine, so we choose artemisinin in them. It is also well absorbed orally and absorption enhanced by food. So all the anti-malarial drugs are advised to be given with the food for two reasons. One is the food increases the uh, efficacy of some anti-malarial drug like lumefantrine and mefloquine, and also reduce the GI toxicity. Parenterally, it should not be used, and it is excreted in bile. Therapeutic use of mefloquine is one is it can be given to the chloroquine resistant strain of Falciparum and Vivex. Otherwise, as I told you, for long term chemoprophylaxis, 250 mg per week, 2 weeks prior to the travel during the stay, and till 4 weeks After returning from the endemic zone, Mefloquine is the drug of choice for long-term prophylaxis. Sporadic resistance to Mefloquine has been reported from many areas, so this is something difficult and unfortunate thing to report. So current recommendation is based that Mefloquine should be used in combination with artesunate only, not alone, because of the development of resistance. So it should be used in combination with artesunate as artemisinin combination therapy to prevent Mefloquine resistance for uncomplicated falciparum malaria and chloroquine resistant cases. Prophylaxis के लिए we already discussed. There are some interaction of Mefloquine with some drugs like halofantrine, quinine, chloroquine because they are almost similar drugs. So they have a lot of interactions. Like all the drugs are responsible for QT prolongation. So if you give it together, their chance of QT prolongation is more. So which leads to cardiac arrest. These drugs should not be administered if Mefloquine has been given less than 12 hours earlier. So we never give actually this kind of regimen where there is two drugs from the same group is given simultaneously because they will lead to additive side effects. So this kind of combination you will find in market with the name Falsigo. This is the brand name of Zydus Cadila, but there are many other brand names. This is just for example, not for promotion of any particular brand name. That Mefloquine in combination with artesunate is available. So now comes to Piperaquine. It is again chloroquine container, so everything is same. There is nothing much to read in case of Piperaquine, but it is also high efficacy erythrocytic isotretinoin. The action is prolonged, but the onset of action is slow. It is again active in both sensitive as well as resistant chloroquine cases. Whatever drug we are reading apart from chloroquine is to be given only in cases where there is resistance to the chloroquine. Otherwise, chloroquine is the drug of choice for chloroquine sensitive falciparum. But mostly nowadays there is resistance to the chloroquine, so we use these drugs. That is why we are reading it. The combination of Piperaquine is with DHA. We see that combination in cases of resistant falciparum malaria. Now, arteroline Piperaquine combination is available, and dihydroartemisinin Piperaquine combination is available. So let's come to the quinine, which is an